Welcome, everyone, to the Target Investments Stakeholder Public Forum meeting today. Thanks for joining us. Just had a couple of quick housekeeping things for you and for those of you on the phone. So one of the things that our facilities people always tell me is to let you know in case of fire or emergency that our stairs are here outside of this room, right next to the elevator, and we exit to the back parking lot, should we need to do that. But the other things, bathroom down the hall here and to your left. And the way that we're going to do the questions and answers today is for those of you on the phone, we've muted all of those attending via phone. There will be a question and answer session at the end of our presentation. You're also welcome to submit chat. In fact, we encourage you to submit chat questions throughout, and we'll be monitoring those and capturing, so don't use the question feature in GoToMeeting, use the chat feature, and we'll capture those and be responding. Today's session is being recorded, both the audio as well as the PowerPoint deck that you'll be viewing. And so that will be made available on our website following today's meeting. And the slide deck that you're all viewing today is also available currently from our website, the Targeted Investment site. Anything?
Nope, I don't think so. Is this on?
No. All I got is
There you go. All right, not that it matters usually with my voice anyways. So, good morning everybody. Welcome to our updated discussion on targeted investments. We have air conditioning working today.
I know.
For those of you that were with us last time, it's the little things in life that we can appreciate on a June day in terms of just having some cooler air, so all of that is good. We have got a packed agenda today to roll through some details, the application. We'll show you a quick calculation that's up on the website in terms of where you can go in and plug in some information. And most of the agenda does not include me. It includes people that are much smarter than me in terms of all the specifics of what we're delving into. But just to step back up, higher level, sort of a recap of the journey that we've been on. It started a long time ago, State Innovation Model Grant. We submitted that. We actually were denied our $60 million request at that point in time, and it was largely focused on many of the things that we'll be talking today, trying to come up with opportunities to have Medicaid be venture capital or an investment in the delivery system to really look at ways to improve integration of behavioral health and physical health services, to also look at other opportunities around justice. And so much of what we've been talking about, and if you've had the opportunity to meet with myself or staff or hear presentations, you know that we are on a multi-year journey to really look at ways to reduce fragmentation in the delivery system and improve integration at all three levels. And all three levels, probably the majority of you can give this presentation, but all three levels, policy level, having the ability to merge with behavioral health services and have all of that expertise within our organization is a meaningful change on a daily basis in terms of how we address policy, how we look at issues holistically for the access population. Then at the payer level, we've got a lot of work. We've had some populations go into an integrated payment structure over the past few years, and we've got a plan if you're following along. We've released an RFI. We're releasing some of the questions for the 10/1/18 procurement, in which we are pursuing further strategies around payer integration for the vast majority of our population. And today's really focused on that third level of provider integration. What can we be doing to support provider integration for reducing that fragmentation? So we've done some stuff in the past. We worked with DHS and had regulations changed. We've done some things around really looking at incentives for integrated clinics and increasing what we pay for physical health services. But today, and the efforts that we've been on over the last couple of years with our partners at CMS, has really been about trying to identify and leverage Medicaid as venture capital to pay for projects. We're not paying for services. This is not service-based reimbursement. What you're going to hear today is really around projects that need to be completed. So that SIM effort morphed into a DSRIP request. That DSRIP request was for about $1.5 billion. And quite frankly, we all assumed on November 8th that that effort was not going to go anywhere. But our partners at CMS under the previous administration came to us. They said, what we think we can do in the few remaining weeks that we have is put together a very limited targeted investment of $300 million And I think there's an old adage somewhere, if somebody offers you $300 million, you should look at opportunities to take $300 million. And so we were able to leverage a 9-to-1 match as a result of partnering with CMS and MIHS, who's been a valuable partner in terms of being able to put up some of that local match for our IGT that we need to move forward on this. But really what you're going to hear about today is what our plans are for that $300 million. We've had to make a lot of difficult decisions over the last few months, so it's great to have $300 million, but it's not as great as having $1.5 billion. And you have to sort of rescope what you're focused on as an organization and what you think that you can actually do that's meaningful. So that's the journey we've been on for the last few months. And really you're going to hear about that today in terms of what that means for the delivery system and what the projects are that we're focused on and really how to get in the front door and get started on that as we move forward. So that's a quick update on where we're at, and really hardly anything that's on that slide was what I talked about. So again, strategically where we've been as an organization, I know you can't read this, but I put this up here because this is our strategic plan. Hopefully, when you have a sleepless night, you can go on our website and look to see what it is that we're actually doing here at Access. But I will touch on two important goals that we have for our organization: reducing fragmentation, driving towards an integrated healthcare system. And there's a number of strategies that we are pursuing as an organization really to fulfill that goal. So establish system of integrated care organizations. Again, if you look at what's out there coming on the RFI/RFP, you will have read a lot about that. Establish policies and programs to support integrated providers. Leveraging a fully functioning HIE. Data is so important as part of this integration effort that we're all on. And then the other one over here, pursue and implement long-term strategies that bend the cost curve while improving member health outcomes. Obviously, there's some very important debates that are going on at the federal level. And we recognize that has long-term implications for our program depending upon what Congress decides. But we have said all along over the last many months that we have to focus on the strategies that we believe will bend the cost curve and improve outcomes for our members. A lot of that is policy debate that is very difficult to influence at this point in time. But what we can focus on are those types of things and those types of system design issues that we believe are important, will have long-lasting, meaningful impact for the members that we serve. So here's our goals. It's going to sound like a broken record, but reducing fragmentation, increase efficiencies in terms of the delivery system for our members, particularly complex members. And I don't have it in here, but if you've heard me speak again before, you know 5% of the Medicaid population equals 50% of the costs. And in that population, so many of our complex members have both chronic conditions as well as behavioral health needs. So I had the pleasure of going to PIR and looked at their integrated clinic last week, I think it was. I don't know, all the days run together. Last week? And so they shared some data in terms of what their population looks like from a chronic conditions compared to the Arizona population. And the numbers are as you would expect for individuals with serious mental illness in terms of some of the complex chronic conditions. And that's one of the reasons we started with that population for integration. But again, it really reinforced to me the reason why we're on this journey in terms of looking at integrated delivery systems for our members. So, timeline. We are right here on this timeline. It seems like not that long ago, but we finalized the waiver with CMS over the course of the last week of the previous administration. You will hear more about today the TI application process, but that starts next week. It is open for about a 6-week period in which providers can come in and apply to the system. Over the course of the next month or so, we'll be going through that data and really identify those that have met the thresholds of coming in, and you're going to learn more about what that means. But really, in essence, the first year application is pretty simple in terms of coming in if you meet the certain provider types that we've identified for the program. And then the first year really ends, and you'll learn more about what that means, on 9/30, because that's just the time frame of the waiver and what we have. So this is the timeline going forward. It's pretty repetitive in terms of when payments occur, when the different year timeframes are, but we're in essence on a federal fiscal year. for the waiver program because that's what our waiver is tied to. That's how the funding is allocated within our 1115 for the $300 million. But in essence, the payments are one-time payments after the end of the year. So our goal would be to have the first year payments go out in the fourth quarter of the calendar year. And I'm not sure, that will be our goal going forward, but some of it will be dependent upon data collection and things like that. So I'm not going to sit here today and promise you it will always be within that time frame, but that's clearly the time frame we're starting as it relates to the first year, hoping as we move forward in all of this. So this is the allocation of funding. Again, we had to make very difficult decisions. $300 million does not equal $1.5 billion. So that means we had to focus the dollars, and we felt the best place to focus the dollars was at the service level in terms of where individuals go to care at the right place at the right time, and it's largely focused at what you'll see as references ambulatory, but what we think about is primary care, clinic site, in terms of individuals that are being served within that setting. So the vast majority, and you'll see the different provider types that are associated with that in just a minute or so, but these are the dollars that are allocated. So it's a bell shape. We start with a little bit, we ramp up to about $85 million in year 3, and then it starts ramping down over the last 2 years of the waiver. You see the allocations here. We have funding set aside for justice, so this is to establish integrated clinics at a limited number of sites for probation and parole. And the REBAs will be working with providers on that project. And then the last piece, we recognize it's not much money, but again, part of the difficult decisions, we limited the dollars going to hospital because again, we wanted to focus our investment right here, largely on the integration opportunities that exist between behavioral health and primary care and specialty services. So that's our focus in terms of the dollars and how they get allocated sort of by year. So I'm probably not the best one to be explaining this slide, but there are a set provider types that are eligible to participate in the targeted investment. And that does not mean when you see the application later that you're applying for each individual provider. What you're applying by is the different sites affiliated with provider types. And so others that have more ability to communicate that to you will talk about that than me. But just understand in terms of when we're talking about target investments, who's eligible, there are ways to aggregate these provider types to the site. And you'll see that in the details as we roll forward. So some other criteria, you got to be a registered provider. You have to use an EHR consistent with access standards to exchange with the HIE. And then when we go through the calculations, you'll see later, there are minimum thresholds that we are looking to establish, both in terms of the number of access members you have impaneled to you from the primary care side, also from the number of individuals impaneled to you from an MCO, so aggregate as well as individual MCO. We didn't want to spend $10 cutting a $5 check, so we wanted to establish some thresholds that made sense in terms of looking at that. And then on the behavioral health side, the calculations are done in terms of looking at utilization, not attribution, from the perspective of that. So thresholds, again, more details about that as we roll forward. So the final slide for me before I turn it over to Michael Baylett is the flow of funds. So again, we partner with CMS. We'll draw down the federal monies. We have to leverage an IGT for part of these funds and our partnership with MIHS as part of that. We'll do the calculations in terms of how those funds should be allocated to various providers based upon some of the data I mentioned earlier, contributed lives, behavioral health utilization. For inpatient, it's the number of admissions with a behavioral health diagnosis. The MCOs, our partners, our contractors, are then responsible for passing through those dollars to providers based upon the way it gets allocated and our calculations. And so that's the flow of funds as it will work on an annual basis associated with targeted investments. So, a lot more detail to come. I'm going to turn over to Michael, unless there's somebody has a burning question now, but I would guess that a lot of questions you may have are going to be answered in the next segment. So unless somebody has a burning question like what's going to happen with repeal and replace, and I have no idea, then I will turn it over to Michael. Thank you.
Good morning, everybody.
Good morning.
So I'm going to cover a lot of content with you. I'm going to start by talking about how the target investment payments are going to be calculated, and then I'm going to talk about what providers need to do to earn the payments. So let me start with the slide that's already up. Criteria for payments in year one. So the mechanism for determining payments for the first year is different than what it will be for the subsequent years. So for year one, payments will be distributed to eligible provider organizations. Tom showed you a prior slide with eligible provider organizations. So if an ambulance company were to submit an application, that would not be eligible. But if a provider is eligible, it really needs to do just three things. Complete an online application in time, which is in July, document that it's utilizing an EHR, and for ambulatory sites, complete a behavioral health integration self-assessment. And you can see here, there's a link to a series of assessment tools at the SAMHSA website that can be used. There's not a requirement to use just one. But there has to be demonstration the organization has assessed where they are along a continuum in terms of behavioral health integration. Okay, so this is year one. It will be different for subsequent years. So I'm pointing the square, George. Yeah, over there. Maybe.
There it is. Oh,
No. Got it. Bree, can you move it forward?
Let me find out.
okay.
Okay, thanks. All right, so years 2 through 5. So years 2 and 3 are different than 4 and 5. So for years 2 and 3, again, fixed to the federal fiscal year, participants can earn incentive payments by documenting that they've completed milestones. So the Target Investments Program is organized, as Tom said, around projects, and within projects, there are core components of the projects. And for each core component, there's a milestone. And so achievement of milestones dictates in part the size of the payment. Okay, and there's a whole target investment vocabulary that I'll be going over when I talk about the projects themselves. But know that for these first couple of years, you have to demonstrate, when I say you, providers I'm speaking to, providers have to demonstrate they have achieved certain milestones related to the projects. And if they are partially completed, then the payment is less than if they are fully completed. This is just for years 2 and 3. The providers receiving the payments have to have served a minimum number of access members, and I'm going to talk about how this is going to be calculated a little bit later. Years 4 and 5 are different. So years 2 and 3 are really about doing the projects, and years 4 and 5 payments are geared towards performance on a set of quality measures. It should be the case that successful performance on the projects during years 2 and 3 should support performing well on the quality measures in years 4 and 5. But the basis for payment distribution changes, and I will say also, to be honest, the bar raises too. I think it will be easier to complete the milestones than it will be to make sure that you've demonstrated high quality or quality improvement, as may be the case across the measure set. The process for determining, whoops, how did that happen? Okay. The process for
think we went forward 2, so the next one would be right here. Nope. So that's the one that we were just on. That's the data on 114.
All right. Okay, so the process for calculating the payments differs based on the type of provider. So for a primary care practice, we're going to use the number of members that are enrolled through an MCO or assigned with that practice. And when I say practice, I actually mean practice site. So the targeted investment program is focused on individual delivery sites. And the submissions of documentation of meeting milestones related to core components is at the site level, not at the corporate entity level, because transformation and integration occurs in sites. It doesn't occur at a corporate entity level. So there'll be calculations for each site looking at the number of assigned members for a given site. And we will do this using enrollment data for the most recent available month. And I'm anticipating that we'll update this each year. But for the first year, we'll look at members reported by the MCOs for a given site as of a recent date. For ambulatory mental health providers, instead of looking at assigned members or enrolled members, we're going to look at service utilization provided over a recent 12-month period. I can't tell you the exact 12 months, but it will be the most recent 12 months for which Access has completed claim data. Okay, and this will be only for certain services, not for every possible service that the provider delivers, but for certain outpatient services that are consistent with the focus of the project. Yes?
You may get to this later, when I'm kind of looking at this and who can apply it. Let's say several different types of organizations, or even the same types of organizations, we're going to work together in partnership on something like this. Should they, let's say you have multiple organizations, either different categories, some of the same categories, who want to work together in partnership for a host of different reasons. Would you prefer that they apply as a partnership group, or each one apply individually and then work together with the funds that are available?
So the evaluation is all going to be done by the site. So what?
Application is by the site,
Right.
because we had to construct a format to do that. So the application is by the site, the format, when we look at plan attribution, as it relates to members, it's by the site.
And we can only pay a registered provider. So if you enter into this partnership you have to be registered with Access.
So it'd be better to work together if you do it in partnership. There are organizations that are involved in this individually.
We strongly encourage collaboration and building partnerships. The way that we can structure this is at the site level, and that's the way we're going to have it.
That's what I was asking.
There you go.
Okay. And I'm not going to get into what are the individual service, categories, but just know it's not for all services. And then finally for hospitals, we're going to be looking at discharges to the community, and it's discharges to the community for individuals with a primary mental health discharge diagnosis, a primary substance use disorder diagnosis, or individuals who are adult members with an access designation of SMI. Okay, and again, we're going to use, as with mental health, we're going to use most recently available 12-month period for counting of discharge. Having a lot of problems with this. How come Tom didn't have any problems with
I'm
it?
going to change it for you.
Can you do it for me,
You
Rick?
have to be the Access Director.
Yeah, Special Access Director privileges. Okay, so what I just described is the approach for the first year, for the payments happening in the fourth quarter of this year. It changes for target investment years 2 through 5, because we're not just going to consider essentially the volume that the site's seeing, but also the performance against the milestones for years 2 and 3, and targets for the quality measures in years 4 and 5. The milestones are weighted. So some of them are bigger lifts than others. And in fact, when you see the graphics we're using for the weights, they are barbells, okay? More barbells means a heavier weight. And so that will be part of the calculation of performance in terms of achieving the milestones. Ready? Okay, so simple math, primary care mental health hospital, the initial year, it's panel members, service utilization units or discharges, times a dollar value per member per year, per service unit per year, per discharge per year. Okay, the years after that, there's a third element of the multiplication, and that's the value of the milestones achieved relative to the total available. Okay, but milestones or years 4 and 5, the quality improvement targets. Okay, so this is just an example. So we took a primary care site with 2,000 access members. That's about one full PCP panel, roughly. And we said 1,000 adult members, 1,000 pediatric members. They got all the milestones, so how much money might they get? This is an example. The final numbers are not set because the amount that providers will get will be based in part on how many providers apply and are accepted into the program. Okay, because the amount of money that Tom described, the $300 million, that's fixed. So we have to learn over how many providers are we spreading the dollars, and are they big providers or smaller providers? But this is an example. Now, you'll note that this assumption is 1,000 adult members and 1,000 pediatric members. The payments that go out for adult members and for pediatric members in future years will be different because the pediatric practices will be asked to do different and actually more than the adults. They're going to have some additional areas of focus that are very specific to kids, specifically kids with ASD and kids in the foster care system. Okay, so knowing what the mix of adult pediatric members is has impact for the primary care site and also, for the mental health sites on the value of the payment. So let me talk a minute about thresholds. Tom referenced this briefly. There are two types of threshold calculations Access will be performing. The first is at the provider organization level. And simply put, a provider needs to demonstrate that it has enough volume, either in terms of members or service units, to qualify for participation. If the number is so small that Access would estimate that the payment that would go out would not be sufficient to sustain the work to be done, then that provider will not be eligible to participate. That assessment will be done not at the site level, but at the organization level. So it's possible there might be a multi-site provider that's got huge numbers of Access members at 3 sites and hardly any at 4 sites. But if in total it has enough, it will be eligible to participate. Then it will be up to that organization to figure out how it's going to sustain financially the activity at the smaller site. Okay, but it's an organizational level assessment as opposed to a site assessment. So that's the first threshold. The threshold is not set yet. Again, it's dependent on how many providers apply. We don't know the answer. So that threshold will be defined after the applications come in. The second threshold is an MCO level threshold. We've done some analysis and looked at volume in terms of members and outpatient services and discharge for providers by MCO. And not surprisingly, you might find a provider that has significant volume with 3 MCOs, but there might be a 4th where it's 5 patients we're seeing. So we're going to set a threshold so that MCOs are not sending out checks for $4.35 or some amount that just doesn't make sense just in terms of the administrative effort. Again, those thresholds are not yet defined. They will be after the applications come in. Okay, here's a simple example. Let's assume a threshold for primary care is 500 members per organization and 50 per MCO. So provider organization number 1 contracts with 5 MCOs across its primary care sites. You can see here there's a lot of variation by site. Overall, there are 600 members, so that's enough to get in, but there's one MCO that has only 25. And so if we set the threshold at 50, that MCO would not be obligated to make a payment for the 25. Okay, this is totally fictitious, but just to give you a sense of the concept. Okay. Okay, so what's required to receive payments? So there are some reporting or documentation requirements for core components in years 2 and 3. Nothing's required in year 1 except for what's required in the application, and in years 4 and 5, it's really performance on quality measures. So this documentation is really just for years 2 and 3. There will be an online portal by which sites, and again, the reporting and the accountability unit is the site, by which sites will provide documentation of meeting requirements. And they'll do it in different ways. Sometimes it will be attestation, sometimes there'll need to be some information. So for example, for primary care sites, part of the payment will be to support a care management function focused on high-risk members. So there'll need to be some documentation that you've actually hired a care manager. And you can see other examples here: participating in training, use of integrated care plans, and the results of self-administered record reviews to confirm that certain protocols and guidelines have been implemented.
So Michael, I just want to reiterate, this is not going to be on the application that you see next week. This is part of the future updates of the application at a later date when we go out and we capture information from you all around future years. Not part of the application next week, but future years.
Right, and we're anticipating that after the applicants have been accepted into the Target Investments Program, that there'll be some more information provided to the participants on, well, so exactly what do I need to do in the coming year? And the project core components and milestones describe what's required in some detail, but certainly there'll be questions you'll have questions about what do I put into the portal and all that, and those details will be described later, but you don't need to know any of that for purposes of applying right now. But you should assess what will be expected of me later, if you're a provider, so that you're not signing up for something that actually you think you don't want to or you can't do in the future. Okay. So how much can you earn? As Tom explained, the dollars are distributed across the projects. We have created a tool that will allow you to estimate the payments that you might be able to receive if you meet all the core components, and again, the quality measures in the later years. And so there'll be an online calculator. You can put in some information about your site or your organization and get some sense of what the payments might be. Okay, I say only some sense because, again, we're not setting the values until we know how many providers are participating. Okay, but this at least will help you a little bit. All right, so I'm going to transition now from payment to the actual activities that need to be performed to earn payments. And I'm going to start with a little target investment vocabulary. We've been using these terms a long time, but and so we have some familiarity with them, but they're new to you and we don't want them to be confusing. So, a few concepts. Projects, that's the overarching structure. People are doing projects. But within the projects, there are what we are calling areas of concentration. I'll explain those. And then within each area of concentration, there are core components, which I've been referencing. Those are the things that have to be done. And then there are milestones, or years 4 and 5 targets. And that's how you demonstrate that you've earned the payment. Okay, so we have some graphics to explain this. So here's the Target Investment Program. There are 2 projects, ambulatory and hospital. Underneath ambulatory, there's a lot of activity, okay? Under ambulatory, there are 3 providers types that can participate: primary care, certain outpatient behavioral health providers, and integrated clinics. Those 3 provider types can participate in different areas of concentration. So I'm going to go from right to left here. So first, children and youth with behavioral health needs. Both primary care and outpatient behavioral health providers can participate in that area of concentration. The same is true for adults with behavioral health needs. And for providers that serve both children and adults, they can participate in both children and adults. If you only serve children, then you just participate for children. Okay, but there's the option of doing both. The third area of concentration underneath the ambulatory project is adults transitioning from the criminal justice system. There used to be, I don't know if it was on Sesame Street, they do a little jingle, one of these things is not like the other. Anybody remember that? Okay, this is one of those things that is not like the other, okay? The justice area of concentration is going to involve a very, very small number of providers. It's going to be a select number of providers that will be identified by REBA's working with Access. And specifically, they will be sites that are at or very close proximity to parole and probation offices. And the whole process for calculating their payments is going to be a little bit different. Okay, so I'm not going to go into a lot of detail on how that works, but for the huge volume of behavioral health, primary care providers, and integrated clinics, it's going to be the adult and pediatric with behavioral health needs area of concentrations that will be of most interest to you. Hospitals, pretty simple. It's just hospitals. And it's just for the specific adults that I described earlier. So this is an overview. I'm going to now go into a little bit more detail for each of these types.
Michael, can you repeat integrated clinics and what they're eligible to do? Because I didn't.
So integrated clinics can participate for both behavioral health and for primary care. Okay? In order to participate for primary care, though, they have to have MCO-assigned primary care lives. So if there's an integrated clinic that has primary care on site, but it doesn't actually have panels of MCO members, then it could not participate in the primary care area of concentration. Okay? But if it does have a panel, then it could participate in both.
Michael, can we just clarify when we say assigned panel, we don't mean you provided a service. We mean you were the assigned PCP for that number.
Right. Health plan says we have 47 members at that site for primary care with these 3 PCPs.
I think that's important is the plan tells us who's assigned.
Right. So all this information for primary care comes from the health plan that says, here's who we have assigned to which PCPs at which sites. And that determines the calculation for the primary care payments. Okay? For the outpatient behavioral health and for hospitals, it's looking essentially at adjudicated claims and services that have been delivered.
So Michael, will the health plans or will Access be providing a list of those attributed
I'm
members?
sorry, can I have you?
Like Tom, I'm surprised people need to hear a microphone in front of me. The question I was posing was, will the provider community be able to access a consolidated roll-up of their attributed members by site? So that, for example, one of our sites in Avondale will have Mercy Care, United, Health Choice, who's one of my buddies, and just so we can see that, or is that just something that Access is going to, where can we make sure that we're tracking on with the same numbers that Access is seeing and that the health plans are seeing?
Okay, so as of right now, we don't have any plans to a priori provide you with those numbers, say, over the next month. But we are anticipating that Access would provide you in concert with the payments going out, documentation that would say you are to receive this much money for these projects in these areas of concentration for this number of members.
So this is going to be an evolving process, right? We get that file now. That's the file we're going to be using to make this calculation. We do anticipate, as part of this going forward, it will further engage the community to have conversations around ensuring the quality of that data that the plans maintain that we get going forward. But we're using the file we have. That's how we're going to make the calculations. And then we fully expect the plans and providers to be working together going forward, because as Michael said, we're going to have to update, we're going to have to use updated numbers in future calculations for years 2 through 5.
Okay, so again, I'm sorry.
I just have a quick question. So,
Yeah.
is this all point in time based? So, am I not loud enough?
No, we've got people on the phone that need
Okay, right. Is this all point in time based, where I know you have to apply by the initial date and be accepted into the program, and then is it fixed in time? So whatever I applied for is all it will ever be, as opposed to a provider who chooses to bring on additional services, move into maybe different integrated
Yeah,
clinics
there's
over
one
time.
there's one application period.
There's one application period, but we anticipate, I mean, again, Michael said,
Things
the key
evolve.
drivers in the calculation are utilization and attribution, right?
Gotcha. Okay.
So that's something that we're making the decision on. How can we update that in future years?
Got
So
it.
we're working through that. We recognize the system is not stagnant. We recognize the member that's going someplace today may not look like that tomorrow, but we're making annual calculations as well. So we're trying to work through that. I don't have a clear answer for you. We recognize that's an issue.
But, and I'm not sure if you were getting at this, but I'm just going to give a theoretical. If you decided in year 3 you want to open up a new primary care site,
Yes.
you can't start participating in year 3.
Yeah, that part.
You cannot.
I think it's clear.
Okay,
Yeah,
okay.
but if you're adding to an existing site.
Right, so if your volume increases over time,
Yeah.
you know, there will be recalculation of the volume figures. I'm using volume as a broad term.
Right.
Okay, so 2 projects, ambulatory and hospital, a lot going on under ambulatory. Let's now start to go into these a little bit more. So this is really an overview. 4 different provider types: hospital, primary care, behavioral health, integrated clinic, and which areas of concentration that they can participate in. This is really the same information I've already shared. It's just presented in a table format in case that's helpful with you, and then a little footnote about one of these things is not like the other justice area. Okay, so let's go through each of these just briefly. So primary care, this is focused on clinicians and practices that provide full primary care services and have MCO panels. And it focuses on adults and or children. I say and because you could have a family practice site, for example, that's serving both adults and kids, who have behavioral health needs. Okay, family practices and ICs can serve both populations, but they have to complete the core components, milestones, and achieve the targets for both populations. There's a lot of alignment in the core components between the adult and child core components, okay? They look identical in a number of areas. They're slightly different in some others. And then, as I said, for children, there are some content areas that are not in the adult area of concentration at all. Okay. Behavioral health. Behavioral health, in many ways, looks a lot like primary care in terms of what we're seeking for integration. Integrated clinics, again, can serve both populations. What's a significant difference if you look at the core components for outpatient behavioral health sites? And we're using behavioral health sites broadly, but most of the core components, to be honest, are focused on mental health. So it could be a behavioral health provider that provides both substance use disorder treatment and mental health, but the core components themselves are mostly focused on mental health with some substance use. What's notable here, if you compare the core components for outpatient behavioral health sites and outpatient primary care sites, is the high-risk care manager function is in the primary care site. It's not in the behavioral health site. In part because there's already some funding for care management for individuals with significant mental illness in the behavioral health site setting. Okay, but there's a lot that's common in terms of what the what provider expectations are for core components and milestones for both provider types. Okay, integrated clinics. Again, I think I've largely covered this. The most important point is this note at the bottom. I think we've already touched upon it. There needs to be MCO attributed panel if it is to participate in the primary care area of concentration. Okay, so integrated clinics can potentially get paid two ways, using the two different attribution methodologies, member count and service units, but they have to do all the work that relates to the two. And I think we have an example of a payment method, a payment to such a provider. Great.
And Michael, can I just add, for integrated clinics, they'll see this with the demo, possibly the application demo, but there needs to be a separate application for both if you're applying for both.
Right, thank you. Thanks, Mikhail. Right. You have to make clear you're applying for both, because an integrated clinic could apply just for behavioral health. So if you want to participate for primary care, you have to affirmatively apply as such. So this is an example. This is actually actual service units for one Access mental health provider. The primary care is fictitious numbers, but integrated clinics can get both, and this is an example of how the dollars might total. This obviously is for a larger site in terms of the mental health line. Okay, then justice system. As I said, this is just for a small number of provider participants that will be identified by Access and the REBAs. The justice area of concentration will have a number of core components that are specific to integrating care for those coming out of the justice system. However, these sites will also have to participate in the adult primary care area of concentration. Okay, because we want them to be delivering integrated primary behavioral health. And the justice-specific core components really aren't about integrated care. So they will need to participate in both. Okay, I'm not going to go into too much detail on this, but that's an important consideration for any providers that want to participate and are tapped on the shoulder by REBA and Access to participate in this. All right, this is a really busy grid, but I'm actually going to spend a little time here because I want to identify what are some of the common core components that are found across primary care and behavioral health areas of concentration. Because this is really the essence of what it is to participate in the Target Investments Program and to deliver integrated care. So one is, while the application for these areas of concentration requires a self-assessment using one of the SAMHSA identified tools, there's also a requirement as part of the ongoing project then to utilize a behavioral health integration toolkit to help guide further integration at your site. And I say further because we know that already the sites are going to be at very different places. Some may have done years of work in integration and some may have done nothing on it. But the toolkit should inform your efforts to evolve your integration and your functionality. 2, across the primary care only area concentration, there needs to be identification of high-risk patients who are tracked in an electronic registry. 3, also, just for primary care, use of care managers for high-risk members. 4, across the board, use of integrated care plans for patients identified as being of high risk. 5, and actually 5 and 7, screening for both behavioral health conditions and for social determinants of health, and identifying community resources and referral and linkage plans for members. 6, protocols for ongoing team-based care. When I say team-based care, I mean primary care and behavioral health working together as a team. 8, using the state's opioid prescribing guidelines. That's just for primary care. 9, bi-directional exchange of data with Health Current. Okay, that's a big functionality, because truly you can't deliver integrated care across settings if you, especially across organization types, if you don't have this functionality. 10, identifying community-based resources. This really relates to the screening. And then 11, prioritizing access to appointments for individuals on the high-risk registry. So these are some common core components that are either in primary care and behavioral health, or just in primary care, but they are core components. If I can be redundant in the use of the word. Okay, great. Some extra core components specific to justice: establishing integrated clinics and contracting with MCOs within or near probation offices, developing outreach plans pre and post release, establishing access to medication assisted treatment, and then having a peer support plan that uses peer specialists as part of the staff of the sites. Okay, so this is special just to those. Hospitals. So as I said, hospitals, this is just for those with a discharge diagnosis of SUD or mental health or member SMI designation. The hospital project is very much focused on care transitions. Okay, it's a narrower focus, and as Tom said, there are a lot fewer dollars here, but it's a much narrower focus than the outpatient. So communication protocols, discharge planning activities, time-sensitive medication reviews post-discharge, and then participating in required trainings. That's the essence of this one. It's pretty simple and focused, but speaks to something that's really essential for good care for people with mental health or substance use diagnoses. All right, so I'm near the end of my journey, but I want to share with you some information about what you should expect to see when you look at the core components and milestones. So this is an example of one of the core components. The core components by areas of concentration are all numbered. You'll see the number in the top left, and then there's a description in the blue bar at the top of the table in terms of what's the content, what is the core component, what's expected of the participating target investment provider. And then for our target investment years 2 and 3, which are milestone measurement periods 1 and 2, because we're not really doing any milestone measurement for the first year, we're just applying, that's it. There's a description of exactly what the site has to document in order to earn the incentive dollars related to this core component. Okay, and we've tried to write the language as crystal clear as possible. I am sure we have failed in some circumstances, and so your questions will help us refine it. But we've tried to be clear about exactly what needs to be done. And And this is a good example here of some of the diversity. The first one on the left for measurement period 1, so this is by September of 2018. And generally speaking, the documentation has to be provided by the end of the year unless otherwise stated. There are some cases where there needs to be something done during the year. For example, hiring a care manager for the primary care site, it's during the next year, not at the end of it. But these are examples of different types of documentation. So the first one is document and attest to implementation of protocols. So there are some cases in which organizations are just required to attest that they did something they're required to do. There's no document that has to be submitted. It's an attestation, yes, we did it, okay? With the knowledge that Access could potentially come and knock on your door and say, okay, show us you really did it, but it's attestation. But B is list the names of community mental health and PCPs with whom written protocols have been established. So here you have to provide some information and say, we've actually done this and these are the people with whom we've done it. Okay? Then for measurement period 2, this is another example of a different way in which you would document performance. So this requires that you conduct your own random sample of 20 discharged members with a primary diagnosis of mental health, substance use disorder, or it's an SMI, actually in this case, I think it's just, or with SMI designation. And you have to attest that after doing that review, a certain percentage of the time, the patient's community mental health provider or PCP was asked about the patient's mental and medical health history upon admission. So you are doing the review and sampling, and then you have to attest that you actually met that standard. Okay? So there are different ways in which you will document whether you've done something. This is the general format in which we are providing information regarding the core components and the milestones. Again, this is only applicable for target investments years 2 and 3, because in years 4 and 5, we move over to using the quality measures. Okay? All right, so before I go on and invite George up, we have enough time for some questions?
Well, Michael, I think that Tom wanted to go over the calculator on the website. Did you want to do that before we did the application or after?
Well,
Michael's up there?
Fresh, yeah, let's have the
Yeah.
questions from Michael first.
Okay. Any questions?
You've got one mic, too.
Thank you. Twofold question. FQHC and FQHC lookalikes are included as under the site definition?
They are not.
Okay.
They are not.
Okay, then my second question is irrelevant.
And just, and a footnote to that, Mike, is that for justice, and we've communicated this, there are some exceptions there. So we'll be communicating that with the REBA, we'll be communicating that with your.
Thank you.
Mikhail?
Question on the justice. One of the footnotes there was MAT, access to MAT. Will the provider need to provide MAT services out of the integrated on-site probation department, or work in close coordination and collaboration with an existing?
Well, Mikhail's right next to you, so I'll let her answer your question.
Ideally, they would offer that service within the clinic. I think we're open for expecting proposals to share and explain how that relationship would work. So if there is some relationship that you would want to establish, we'd be open to looking at that. But it certainly needs to be easy access and available.
Any other questions? Okay, then why don't we go live with the demo?
Do you want to do the application demo before we do the calculator?
Why don't we do the calculator and then we'll do the application? Is that okay? Sure.
Take a quick peek at those chapters.
So Bree's calling up the calculator that I referenced before that will allow you to estimate what you might potentially receive. Again, this is an estimate. Okay, an estimate because, as I probably explained 4 or 5 times, we need to know how many providers apply and who they are in terms of their volume. Okay, so this is what it looks like. It's pretty simple. You would identify your provider type and your area of concentration. Okay, and B, I don't know if you're able to do this or if you just want me to show the slide, the layout. Okay, so there's a drop-down menu. Rhea is a primary care provider. And she's going to participate in adults with behavioral health needs. Okay? So, you would then, in that colored box, indicate, because you're a primary care provider, how many adult members do you have that have been assigned to you across your MCOs. Hopefully you know that. I don't know if that's the case, but hopefully you're getting panel reports from the different MCOs, and you add them together and say, wow, we're seeing, why don't you put in a number, Bree? 600. Okay? Table below will then tell you for 600 members, what's our estimate right now of the size of the payment that you might receive. Okay? And then you can decide, looking at what's requested of you, is that enough money to make it worthwhile, specifically given what's asked of you? Okay? And in this particular case, you might decide, well, that's attractive revenue, but given all that I'm supposed to do, I'm not sure that's enough. Okay? But this is at a site level. So if you're an organization and you've got a number of sites, you might say, well, for this site it looks a little low, but I've got 5,000 members at another site. So it makes sense for me to do it as an organization, and even though I don't have a lot there, I want to do it for all my sites. Okay? This is just to give you a ballpark estimate. Yes?
Is there a restriction about billing, regular billing for these particular patients? In other words, if a provider receives this grant, are they restricted to only this amount for these patients, or can they still submit other billing as they normally would?
It's business as usual. Okay? These are not service payments, as I think Tom explained. These are payments for you doing projects, and in time for improving performance on quality. Okay? But you continue to deliver care and bill care as you normally would. Any other questions? Okay, George.
I guess, Michael, can we just repeat, because since my area is determining payments, I want it very clear that everyone here understands these are just estimates. Just estimates. We don't know the actual payments because we don't know the threshold yet.
Right.
So we don't want to get phone calls saying, my calculator said I would get $100,000 and you only paid me $50,000. The calculator is just to help guide you. No phone calls.
Now that being said, don't call Shelley. But we tried to be conservative. Okay? In our assumptions, we've assumed that there will be broad participation. And when I say broad participation, I actually mean in terms of the percentages of services delivered, not the percentage of providers. Okay? We are assuming that the providers who represent the vast majority of these services will opt to participate. So I'm guessing that if we're making an error in one direction, hopefully it's to your benefit and not in the direction that Shelley is describing, where your payments actually half. Because we're assuming that most providers would say, yes, this is attractive, let's do it. Okay. All right, George.
Well, good afternoon, or past morning now. So, actually, there's a slide, but that's okay. Next slide, sorry. There we go. Okay, so I'm going to talk to you about the actual application, which we have been developing with our Information Services Division team and another Access folks. Before I get into this, I want to emphasize, and I'll mention it a couple more times, there will be detailed instructions accompanying the actual automated application that will be accessible through the Targeted Investments website. So there are a few reminders about that before we get into the actual demonstration. As Tom and I believe Michael mentioned, we're anticipating releasing the application or having the application available in the middle of next week. And we'll have it open for approximately 6 weeks till the end of July. The determination about who will actually be included as participants will take a little bit of time. We're going to need to go through those applications, make sure that only the eligible providers who registered are included, make sure that there's a number of other checks on the data and so forth. So that will take, we're anticipating a few weeks, but sometime in August we're anticipating that we'll be able to identify who the participants will be. So, and hopefully many or most of you are already aware of this. We have had this information posted on our Targeted Investments website or webpage. To get into the application, you must have an Access Online account, and we'll talk more about that in a minute. And if you do have an account, that information needs to be updated, or review it to make sure it's updated with the Access Provider Registration Unit. As Tom and I believe Michael also mentioned, one of the prerequisites is a electronic health record that is able to exchange information with other organizations. Michael also touched on this, but the application will ask you to confirm that you have completed one of the integration self-assessments. You mentioned the SAMHSA website. There was a link on the previous slide. I believe there are 4 options, 4 types of assessments that you can utilize, and the application will ask you to confirm that you've completed that. And then finally, just familiarizing yourself with the information, with the areas of concentration, core components, and much of the information that Michael's gone through this morning. Okay, so I am going to kind of narrate, and Sarah's going to run through the actual application and give you a sense of what that is like. Again, there'll be detailed application instructions on the Target Investment webpage. That'll be coming soon. And so, assuming you have a Access Online account, you would enter your username and password. If you don't, there is on the left side where Sarah's pointing a button that you can initiate the registration process with. And you would click there, and there's some information that you'll need to do that, NPI and TIN, tax identification number, or the Access ID and TIN. So once you have that established, Sarah's going to log in.
Everywhere.
So if you'll notice on the left side where Sarah's pointing is the Target Investments program link. Will bring you to this page. And as I mentioned, there'll be reference to the self-assessment. And there's another link to the overview of the program.
George, microphone. Folks on the phone can't hear.
Okay, how's this?
Better.
Okay.
You can pull it up,
Yeah.
George.
This will work. Okay. So these are the links to the self-assessment tools that are through SAMHSA. Okay, so if you go down to that first button, Sarah, where we have electronic health record, could you hover over that for a second? So this, when you hover over electronic health record, it'll tell you exactly what criteria we're requiring for that. If you click no, it will stop you there. So we'll click yes. Okay, and then you go down to the button on the very bottom there, and you will select what type of organization you are. And it'll ask you one more time at the very bottom, have you completed the self-assessment? And again, it will stop you if you haven't. So we're going to click yes. Okay. So we are going to use the behavioral health clinic application, and I want to just pause there for a second. So the process for both behavioral health clinics, provider type 77s, as some of you may refer to them, and ICs will follow this application. You can see those are listed there below. But we're not going to have time to go through it today, but there's another application portal for the primary care providers. For behavioral health clinics and for hospitals and for ICs, we'll be using the Access Provider ID, okay? And that will enable, and we'll show you in a second, that will drop down the service addresses that are associated with that provider ID. For the PCPs, you'll be using your tax identification number, and unfortunately that does not pre-populate, so there'll be a box where you will enter the actual service address for the sites that you are wanting to participate. Okay, and again, the application instructions will detail that and walk you through that process. So Sarah, you want to enter a provider name? Okay, so in this case, there's one address, which we have chosen, and we will choose whether it is a behavioral health outpatient clinic or IC. In this case, we've chosen behavioral health outpatient clinic. Then you'll identify which plans, which MCOs you're contracted with. And then, again, you'll note at the bottom what areas of concentration you're deciding to participate in. So it will identify whether you want to participate with children or adults. And once you hit Add Application, it records your application and lets you add another site. Yes?
Is, when you say what access plans we're contracted with, but this is for behavioral health services.
Right, but if you'll notice, there are also REBAs listed there as well.
Okay, but if it's an integrated care clinic, would you then list all of the ones you had for
Okay.
primary care and for behavioral health care?
Right, so I'm going to go back to what Michael and I believe Tom mentioned earlier with integrated clinics, and that is that obviously you can apply through this portal on the behavioral health side, but if you have members attributed to you by a plan, primary care, then you would go into the primary care application and complete a second application.
So, but George, I think the question maybe she's asking is if she has a contract with United for the physical health services that she does provide, regardless of how she goes about applying for the primary care project, should she check it here?
Right.
Because the contract isn't for mental health services.
Yeah, I don't think so, because you're going to be, you're going to be wanting to connect those services to the plans through which you're
It
being.
can't hurt if she checks.
I don't think so, but I,
It won't be
you know,
required.
do you think so?
Someone should validate that.
Pardon me?
They said someone should validate that. We probably need to just make that a policy.
Okay. We will validate that and confirm that with you and address that in our FAQs. Yeah.
I'm not seeing any Advantage plans listed. Are they just considered, like Mercy Care Plan would include the Advantage plan?
No, these are only access plans.
Okay.
Medicaid plans.
Medicaid, all right.
Yes.
Gotcha.
Yes.
Even though they're the primary?
Well,
Person
again,
dual?
What's the question?
Bree, can you hand? the mic?
Maybe I'm getting this too complicated. I was looking for the dual members.
This is not by membership, this is by
Payer.
plan that you're contracted.
Right, so for the duals, you may have a contract with, I'll use this as an example, United for behavioral health services. You may.
Yes,
Right,
yes.
yeah.
Okay. Any other questions before we go on? Okay. So Sarah, why don't you click some of those? Okay, so we'll continue. I got it. And okay, so Sarah's going to complete the as the person completing the application. One thing that I want to note here is that the any follow-up questions that Access has on target investments with your organization will be addressed to the Access Online account holder, okay? Because that's the person of record. So Sarah may be, if Sarah's the person who established the Access Online and is the account holder of record, but she asks me to complete the application, if we have any future follow-up, it will go to Sarah. Okay. So that is the Access Online pathway to the target investments application. Any other questions? Okay. Sarah, can you go to the next? Next slide, please. Okay, and Michael touched on this earlier, but some of the core components involve education and training and technical assistance. And as we move forward, Access will arrange or help facilitate or convene, where appropriate, some of those opportunities to get that training and assistance. And in some cases, the core components involve that training as a necessary component to meet the milestone. Also, the managed care organizations will be able to refer any questions that they have. They'll be your first line of inquiry for questions, and we'll have a process for the MCOs to work with Access to resolve any other questions that they can't address. And as you can tell, there are lots of moving parts to this, and we are continuing to work on many of them. And I encourage you to check back with the Target Investments webpage frequently. For example, we just added the calculator that we demonstrated a few minutes ago. That was just added yesterday afternoon. So there are new updates. We will be updating the FAQs. And I believe many of you hopefully know this if you've been on the web page, but there is also a dedicated Target Investments email account. And some of you I know have taken advantage of that and asked some great questions. To the extent that those are kind of more universal questions, we'll also answer those. Besides directly answering them, we'll answer them and address them in the FAQs as well. So we have questions through the chat, right, Mikal?
Yeah, and if I can give, I apologize, we have just one mic, but some of the folks on the phone are having trouble hearing, so we'll do our best to try to get everybody mic'd. And some of these may have been answered already, but if, I guess, I can go ahead and jump in, and there may be different people that can answer these questions. I know that I won't be able to answer most of them, but are applications by site for health systems that have hospitals and multiple ambulatory sites? Does the question make sense?
Can you ask it again?
So the question is, are applications by site for health systems that have hospitals and multiple ambulatory sites?
Yes.
Okay. Okay, and then our next question is Access going to create a uniform care plan? It will be an administrative and financial burden for providers if each health plan comes up with an integrated care plan. Creating uniform forms, the way DBHS did, would be helpful for providers.
George, can we go back to that other question just to provide a clarification to that? Because
You need a mic, Elizabeth.
So just a quick clarification to the first question so that we're very clear that if you are an entity that has a hospital, you would go through the hospital application and complete it there. If you are an entity, then you have an ambulatory site, you would go through that application and then the sites, so you have more than one, would be dropped down there. And you would enter an application for each one of those sites, okay? And then let's say you have behavioral health as well. You would go through the behavioral health application, each one of those sites. I just want to be super clear because I don't want you to think you're going to go through one application and every single one of your provider type sites are going to be listed in that one application.
And Elizabeth, can you address the paying by site? Because we said earlier paying by site, but if all your sites get the same pay too, we can pay. I don't mean
To that. So let's say you have multiple sites associated with a TIN, right? And you have it established that payments go to, for all of these sites, payments go to this one place. We're able to do that. It's not like every individual site will have to get an individual check. We won't, right. Okay?
Okay, this question is, how would an applicant interested in the Justice Program project know how many patients from the justice system to expect? And so I think part of the answer to this is, so there's no attribution, obviously. We don't have the existing clinics, so there's nothing to base that on. However, we do have numbers of individuals and have worked with the criminal justice system and probation and parole in particular to identify the number of people at different probation and parole sites that are on probation and parole, and have tied some of that to looking at places where we would put the clinics. But Michael can answer better. No? Okay. I think there are still outstanding questions, though, and work being done, I should say, on making sure that we actually identify the number of individuals that would be involved in the justice clinics. Yes, the care plan. We got to go back to the care plan. Thank you. So I hope that answers the justice question. There's more to come on that. So going back to if Access is going to create a uniform care plan. And so I don't think I need to repeat the entire thing again. But
I think that's a business question that we're not.
Right, that,
okay.
yeah, that, I don't know that decision has been addressed.
Right, but as George mentioned, these questions and answers, to the extent that we identify answers to them, will be available in our FAQs. Okay, we are a health system with a hospital, employed physician clinics, whose primary care offices are designated patient-centered medical homes that deliver behavioral health services via telemedicine. Do we apply for each individual operating entity separately? Same question, I think, that we covered.
Right, so I think that's what Elizabeth just covered.
Okay. How are covered lives determined? These patients cross all 3 domains.
Well, again, primary care will be through the reported attribution from the MCOs, and behavioral health and integrated clinics and hospitals will be based on utilization.
Okay, and it looks like the last question is a repeat of the application process that Elizabeth spoke to. I believe that's all of the questions that were submitted via the chat. If not, please submit more.
Any other questions from those here in the room? Okay, well, I want to thank everybody for coming in today, and look forward to interacting with you as we move forward with the project, and be looking at our TI webpage in the coming days as we post the application. Thanks.